welcome to the COBRA lecture series, Rhode Island Hospital lecture series, which today has a participation of the Migrant Communities Project Initiative, part of COBRA's Translational and Transformational Core. I just want a couple of, if you have questions, we'll hold them to the end, and you can type in your questions into the chat box for the Q&A at the end of the talk, and we'll read off your questions. So we're really excited today to have the project team of the Imani Breakthrough Project, what is a really interesting program, an innovative program. Migrant Communities Project Initiative is an effort to, among many, to try and identify, promote community-based harm reduction that brings historically underrepresented communities into the participatory process. The Imani Breakthrough Project is an extraordinarily innovative and efficacious program, and we'll hear today about exactly how that program has been working. In Connecticut, faced with a situation in which there's been a 50% increase in OUD-related mortality among Blacks, and a situation in Latinx and other migrant communities that fail to take into consideration, or often fail to take into consideration, how migrant issues shape health behavior, inform risk, and affect health outcomes. A major effort has been undertaken on behalf of the Imani Breakthrough Project to bring evidence-based programs to populations with serious health and other issues that simply aren't getting help. One of their innovations has been to create a participatory process with peer counselors, and how people from the community are used as facilitators in the program. Another important innovation has been underexplored, which is how churches can be a safe haven for people to feel comfortable to go and speak. For migrant communities, this is especially important, who may face criminal justice issues, especially with deportation, of course, being one issue. But ultimately, church is seen as a non-judgmental safe space where people can speak. Further, many churches, and this has been my experience with work with the Catholic Church on OUD issues, is that oftentimes can be a source of stigma and against the addicted, where for many people that belong to the church, it can be seen as a sin. And what Imani Breakthrough Project is also presents also as a way to help transform churches in how they frame and understand addiction. Ultimately, however, it's really a way to bring people into access services and medicated and assisted treatment who previously have not had access to it. So with that introduction, I would like to invite Dr. Sherelle Bellamy, who's a professor in the Yale School of Medicine and Department of Psychiatry, and heads the Imani Breakthrough Project, speak along with Reverend Robert M. Anderson, who is an ordained elder in the African Methodist Episcopal Zion Church, and who currently serves as the pastor of the Blackwell AME Zion Church in Hartford, along with Graziela Reis, the Imani Latinx project coordinator in the Yale Program for Recovery and Community Health, Department of Psychiatry and Yale School of Medicine, as well as Dr. Mark Costa, who is in the Yale Program for Recovery and Community Health as a research scientist, and also in the Department of Psychiatry and Yale University School of Medicine. Thank you for coming and speaking with us today, and welcome to the COBRA lecture series in Rhode Island Hospital.
Good morning. I'm Sherelle Bellamy, and thank you for having us today. And I'm just going to open up this document here so I can get started. So great. Thank you for having us, COBRA. And thank you for that wonderful introduction, Dr. Miguel. So I just wanted to introduce some of the folks who are responsible for the Imani Breakthrough Project. My co-PI is Dr. Ayana Jordan, superstar extraordinaire. And then we have Dr. Mark Costa, who's presenting with us today, Reverend Robin, Graziela, Reis, and just a host of people, including many people with lived experience, folks from our State Department, et cetera, who are part of our team. And quickly, it's really important that we just do a land acknowledgement. All land in Connecticut was once Native territory. It is our duty to acknowledge that many of the institutions where we work or conduct research are indeed on Native land, and give thanks. Land acknowledgements do not exist in the past tense or historical context. Colonialism is a current ongoing process. We need to be mindful of our present participation. Thank you. And so, interesting, my friend and colleague, Imani Harrington, and the project is not named after Imani. Imani means faith in Swahili. Imani Harrington is a playwright. She's also a woman living with HIV for about 30 years, and she resides in San Francisco. And this is a poem that Imani wrote. She and I are the co-editors of a book of plays and monologue called Women of Color, Positive Negative Women of Color in HIV and AIDS. We need you, our brothers, our sisters, our people. Help us reaffirm ourselves in loving ourselves. Hold us when we can't stand, because soles of shoes have traveled on our backs for so long. We need you, our brothers, our sisters, our people. And to me, this is the essence of the work that we do. It is the why. It's the why for me personally, as a person who is not only a researcher and a bunch of other things, but I'm also a person with my own lived experience of addiction. So starting with the why, and why are we working with churches to do this? And can we collectively figure out a way to do something about it? So we know that for Latinos and Latinx folks and Black adults are less likely to access substance abuse treatment in traditional settings. Racial ethnic minorities in the US less likely than whites to seek mental health treatment compared with other racial groups, less likely to start drug and alcohol treatment. And if they do start, they don't really like the care they receive, lower treatment engagement. And this is where the Black and Latinx church can be helpful. Religion and spirituality enable Black and Latinx people to cope with psychological distress and mind stress. And this is clear in the literature. There's research on this. And actually, my co-PI, Ayana Jordan, also does work around the Black church and its effectiveness across a variety of different areas. In urban Black communities, 65 to 85% of adults attend church regularly and 75% of Latinx. And many studies highlight the importance of church in drug and alcohol use, where members seek help from clergy, that's from pastors, from deacons, from deaconess, from other members of the church. And also the work that Dr. Miguel Moniz does, we also know that many of the other affiliations also have a church base to them, particularly many of the groups and clubs that and affiliations that Black and Latinx belong to. So what does help look like? There's so many different types of help. And this is one thing that we really want to get across to the Black and Brown communities that we're working with. Psychotherapy, whether that's group therapy, peer recovery, support groups, AA and NA, seeking help from an addiction psychiatrist, medication for addiction treatments, MAT, harm reduction, and really community collaboration. And there are a host of others. And I think that we know that from doing this for the last going on 5 years now, that many people are just not even aware of the types of treatment and just supports that are available to the community. So just quickly, as I mentioned, Imani means faith. And this project is a project of funded by the state of Connecticut's Department of Mental Health and Addiction Services through their initially through the state targeted response to the opioid crisis, the STR funds, and now through the SOR, state opioid response funding. And we are happy to have received those funds for the last couple of years to continue this initiative. So introducing Imani Breakthrough. We aim to promote health and healing for ourselves and our communities. How do we do this? By creating a sense of unity, that we are in this together. We create a sense of collective responsibility through a participatory process. I'm just going to pass this on to Reverend Robin Anderson, and she's going to talk a little bit about how we got started with the participatory aspects of our work.
Good morning, everyone. It is so good to be here on today. And thank you, Dr. Bellamy. One of the things that was so crucial and so important to us as a pastor and also to the church, because we are in the healing business. And that many of us, know the mandate of when I was hungry, did you feed me? When I was sick, did you come see about me? When I was naked, did you clothe me? What you have done to the least of them, you have done it unto me. And so very much a part of the church has always been to reach out to the community. Many people see the church sometimes as just isolated, just dealing with their members in the church. But the church is really, the world is our parish. And so we not only have members of our church that certainly we do in-reach with, but also we do outreach, which is out in our communities, that we don't just see ourselves as a church that's at a certain address, but we see us as a church that serves the community. And so many ways we have had persons that have come, to the church and, they're seeking help for themselves or either seeking help for their loved ones. So one of the things about when I first spoke with Dr. Ayana Jordan and also Dr. Bellamy about this project, one of the things that also came up, also which we've also experienced, there's been many times that people have come to us and asked us our advice of working with various populations or talking about a project. But however, they go off with their grant and they write about us and say that it was part of a faith-based initiative. But instead, this was really going to be a faith-based initiative and a partnership, and that was exciting. And so one of the things that we did was that we brought all different pastors of various churches and denominations together. And we began to talk about the opioid crisis. And then also they began to also share about many people that they've sat in also treatment programs. They visited people in treatment programs. They've sat at hospitals, making sure people got beds in various treatment programs. However, it just seemed like people would go in and come out like a revolving door. And so one of the things, and them coming together and really talking about, what has worked, what has not worked, and what are some of the things that they see. One of the things that they all anonymously agree, we need a new model. We need something different. We need some way that we can really work together and really partnership with the community, because regardless of whether or not a person is a member of the church, they do see the church as a safe place to go. And the church has always been in the forefront of healing. Even at the beginning of Alcoholics Anonymous, it met in the bottom of a church, in the basement of a church. And also whatever goes on in the lives of both Black and Latinx, that the church is the central part of it, whether it was in the civil rights movement, even during the time of slavery. Many churches served as the Underground Railroad. And so the church has always been seen as a safe haven, and that really nothing else has changed. So we need a new model. And so a part of that was also to really think about, well, what are some of the things that we need to do? Well, let's really educate churches about opioid addiction. Let's really educate the church about why they really want to be involved, why they need to be involved in this crisis and in the solution, and being part of the solution of this crisis. And what kind of model would that look like? What kind of way can we really work together that the church really feels that they're really sitting at the table, that they're in partnership, and that we're working together? Because our churches also have people that are social workers, have people that are case managers, have people that work in various kinds of things. And in doing this, will we be able to sustain it? How do we prepare our church to receive everyone, to understand not only about addiction, but confidentiality, some of the best ways to actually work with persons in the community that are dealing with opioid addiction and other addictions that they have? We know that Glide Church in San Francisco was at the forefront of crack when crack was an epidemic. And so we know that the churches are able to provide these services. We do it, but however, we have very limited resources. So this was going to be a great opportunity for us to be part of that. So even in the educational group, they're educated about addiction. They're educated about the way in which the project will work and who the facilitators should be. They're educated about the citizenship model. They're educated about the 8 dimensions of wellness, and then confidentiality. But so a part of that also really helped us to really begin to solidify this project and know that we were moving forward and working together, and that churches were on board. And not only did we go to individual churches to educate them, but we also went to those churches and they invited persons in the community to come, as well as other churches and pastors to come. To also know what this project is about, and for them to embrace that, even though it may not be at their church, they are able to send persons there that also would be able to receive these services. And I'm going to hand it back over to Dr. Bellamy.
Thank you. Thank you so much, Reverend Robin. You know, I'm always inspired just with what you're talking about, the role of the church and the role of your role, period. And we so appreciate your collaboration on this, in this work. So 2 of the main components of that Robin was talking about, one of the things is through this participatory process, particularly involving people with lived experience of substance use, as well as histories of mental illness, came together and really examined 2 initiatives, and one was the citizenship and the 5 R's, which we studied through the 7 domains, which Mark will talk about later. But the 5 R's are the rights, responsibilities, roles, resources, and relationships. And really connecting people to that sense of community so that they're able to go out and reconnect to the community and have that sense of belonging that they need and deserve to lead the healthy lives they should. The other is the 8 dimensions of wellness, which is developed by my friend and colleague, Dr. Margaret Peggy Swarbrick at Rutgers University Center for Alcohol and Drug Studies now. And so the 8 dimensions of wellness and the 5 R's, we found individually, we found positive results from both of those sort of models, but decided that particularly the folks with lived experience decided that bringing these 2 approaches together is really important to a population of folks who have been really disconnected, and particularly disconnected because of their histories of alcohol and drug use and homelessness, etc. And so Imani is unique from other programming, recovery programming, and one is because it is culturally informed. Lots of education around naloxone addresses the social determinants of health, which we'll go into, but particularly the 8 dimensions of wellness really allow us to do so. I focus on harm reduction. Folks are allowed to come to the program using, you do not have to be substance-free to walk through the doors of the church. It emphasizes mutual support, wraparound support, offers coaching for the individuals, wraparound coaching, training curriculum based on the philosophies of the Imani Project. The facilitators are people from the community and churches, and Imani does address some of the challenges that particularly folks, Black and Brown communities have talked about around concerns around use of, one, not having access to medication for addiction treatment, but also not having a clear understanding of what it really means. And so what is Imani addressing? Lots of different things: poverty, undereducation, hopelessness, vicarious trauma, unemployment, othering, limited access to care, acute and chronic stress, folks involved having legal involvement, racism, housing issues, and a host of many others. And one of them, which is really germane to our discussions here with both Dr. Miguel and Laura, has been lack of family support. And Robin, can you just talk a little bit about the collaborating with the church and the selection of facilitators?
Sure. Thank you so much. So yes, again, one of the things that, many of the churches, and they continue to be very excited about the project and even wanting to know how can they be a part of it. But one of the things that we also knew that with the Imani Project, that the selection of churches were very important. One, in terms of their preparedness and readiness, whether it was due to facility or also the work that they're already doing and how they're really known in the communities in which they served. And so many of the churches in which I really looked at and saw, talked to pastors and talked to church leaders around, some of the work that they were already doing in the community, because it was also very obvious that persons that would be receiving the Imani Breakthrough services would also need access to resources that are also located in the community, but also would need a church that was able to really embrace them for who they are and where they were, and to really work with them to get to that point. And so one of the things that I did look at churches that were already really known and very active in the community and doing, whether it was, food giveaways, some of them do financial assistance, some of them have job readiness programs and various other harm reduction programs as well. So I knew that those churches would more likely, and also were located in an area in which it would be easy access for persons in that community to be able to come. And so a big part of it also was to also pick facilitators that were also in the church, and also letting the church know that the pastors needed to be involved, but also more so having facilitators that they know that are part of their churches that will be able to facilitate, and really to have lived experience, at least one of them to have lived experience, but also even having the other, if not two of them, to have it, and also understanding that they would receive training on the citizenship, the 8 dimensions of wellness, and the Imani Breakthrough model. And also that they would also receive a stipend for facilitating the groups, as well as the participants would receive a stipend for also coming to the groups. And then also that they would also be able to receive funds to be able to provide snacks or whatever they needed to provide, a certain amount each week. And then also, even in, providing, the snacks and everything, the church also would receive also funding for hosting the project at the church a couple of times a year, every time a new cohort started. And so in talking to the churches, also immediately, most of them, again, because as pastors, we know who are in our churches. We know who has lived experience. And then, so they were able to pick those two people, and they came to be trained as facilitators. And many of the pastors also, which I tell them all, came to the training also, because they also wanted to make sure that they knew also what they were also being trained, and they wanted to support them, and they wanted to make sure that they had a clear understanding of it also, as they continue to also encourage their congregations and people in the community to also be a part and to support the actual project. Now, a lot of the churches also really took it, and then they developed ministries from that. So some of them knew that some of them needed toiletries. So they developed a ministry that through their missionaries that put together toiletries, and they were given out. Some churches also knew that they needed showers, and they had facilities for them to be able to take showers and put on clean clothes and make sure that they had clean clothes. But also the good part, the greatest part of Imani is the church can kind of make it whatever they want to and expand the ministry to really be able to meet the needs of the persons that are there. And some of them do snacks, some of them do a full meal, which is really good because some people don't get that kind of, as they say, home cooked meals. And so some of the churches actually, provide home cooked meals. And so, there were some churches also that I met with the pastors, and then they asked me to meet with their trustee boards or their deacon boards or their church, whatever church leader boards, and to explain the program. And also really to talk about the fact that we're not forcing religion upon them, but we're providing a service. We're providing ministry for those that will be coming to the church for the Imani Breakthrough intervention groups. And so some churches really felt like it was not for them. And then some churches felt like they embraced it. They were ready. They were willing. And even now I hear from churches all the time, is the Imani Breakthrough going to expand? I'd like to have it at my church. And so, again, those are some of the ways in which and then what also happened, which was really a great thing, I keep in touch with the pastors and kind of talk with them. So after the Imani, the 12 weeks, it was 12 weeks that the Imani intervention groups had take place. They said, oh my goodness, people are still here. People are still coming. They want to be a part of it. What can we do next? And so that's how also what was birthed out of that was also the 10-week Next Steps group, because the pastors were actively saying that they need more, they want more, they're not leaving, they're coming every week, they're coming at the same time looking for these services. And so we were able to also be able to extend the program for another 10 weeks. And so again, the pastors, that's the greatest part of this, that the pastors continue to be in partnership and are very active, with understanding. And then the other thing is that it was a concern, well, if we're giving them $10, people say, well, isn't that helping them to use or transportation? But one of the things that also has come out of this is that even with giving them the $10, after a while, people don't even remember that they're getting the $10. And some of the times the facilitators have to chase them down to give them those $10. So it's not really about the group, but it's about them really feeling safe, really feeling that people really care about them, and that people are not just care about them to come to the groups, but they also have extended themselves beyond that and meeting some of the other needs that they may have as well. And so many people have said, I just feel safe, I feel comfortable. And many people will never join the church. And some people have joined the church, but it's really, again, about providing a service and providing ministry that continues to help people to get well.
Thank you, Robin. And so the overview of the Imani Breakthrough Intervention, Reverend Robin just talked about it. So the first 12 weeks really focuses on education and classes and mutual support around the 8 dimensions, the 5 R's, as well as medication for addiction treatment, harm reduction, et cetera. And then part 2 is the 10 weeks mutual support, which is Actually, so coaching still continues during that 10 weeks, but coaching becomes less and less over time. And what we hope to happen is that the group really sees each other as support at that point. Graziela, would you like to talk about some of the ways in which we have marketed to Black and Brown communities?
Yeah, sure. Thanks, Dr. Shurel. Good morning, everybody. Thanks for having us here today. Promote the program at the community. It's an important part of the program. And the way that we have been doing that, it's collaborating with the local radio stations and talking to the people and invite the facilitators to be with us and talk to the community. One thing that is very helpful, it's when somebody at the community see a face that is very familiar for them. So we have been doing that. So all the time that we are invited talking about Imani, you use this opportunity also to educate the community and let them know that is a program for them that's culturally responsive. And if you are Latino or Latinx, we will have the program offering in Spanish. And if you are a Black, we have the culture also offering the program in your culture with your values and what you believe. So talk the language that people are familiar and we respect that. It's so important. We also have been talked to people on the streets, because that is part of the recruitment. It's another way that we promote the program. And when you do recruitment, you go at the streets and we talk to people, we invite them. Also, Imani was recognized one of the best practice programs in churches, and we're so happy for that. We also work with the mayor's office and the community leaders to talking about the program, and cities has been adopt Imani as a strategy. So we are always in communication with the community. We're always there talking, promote education, and invite people to join the program with us.
Thank you, Graziela. And now I'm going to have Dr. Costa talk about some of the preliminary data from the Imani Breakthrough Project.
Thank you so much, Dr. Bellamy. I'd like to speak a little bit about the data, but before that, just to talk about myself, I'm a psychiatrist from Brazil coming here, and this program has been such a learning experience for me, and I think it's very transformational. And under the leadership of Dr. Bellamy and Dr. Jordan, we were able to create a program that came from the people in a participatory way. But it's interesting that so many great ideas not necessarily translate into good results. But here we've been collecting some data showing that we are really not only reaching out to the people in need, but also achieving very interesting and significant results for them. So about the people who are coming to the program, it's important to notice that it's a church-based intervention, but people don't need to be affiliated to the church to come to the program. You know, it's people don't need to be church participants. They don't need to be members of the church. They're invited from the community, and everybody is welcome. And in our program, you can see that a lot of, or the majority of the people coming to the program, they face several different challenges in their life, and it's sort of this what has been categorized as health disparity population. Majority of people are homeless, have a history of homelessness. They are unemployed. They have several different traumatic experiences during their life. And most importantly, they're currently not receiving services. So the church, Imani, is sort of a place where they can come back to discuss issues about their lives and contemplate also going back to receive the services that they need. So we've been collecting information on the 8 dimensions of wellness and on the 7 domains of citizenship. And we can see here from the results, these are all statistically significant results on the 8 dimensions of wellness. There was significant improvement on physical, intellectual, environmental, spiritual, social, occupational, emotional, financial, and regarding work. So we from baseline to 12 weeks, there is a significant increase in all those domains. And also with the 7 domains of citizenship, we can see also a significant increase in the results. And this is important because as NIMHD has moved towards a multidimensional approach to health disparities, we can see that we need to evaluate sort of all the dimensions of health disparities to see if the program is working, and we can again with these measures be able to evaluate the program and recognize that there is a significant increase in several different aspects of the lives of people receiving services. Also, so we have sort of a quantitative data, but we also collect a lot of qualitative data in this mixed method approach to improvement. And from a series of community conversations with participants, we can see that their statements and what they're saying about the program is really, really compelling, such as people saying that I want to read just this quote, the last 15 years of my life is I did a lot of programs I never finished. I was super negative about life. I never had self-worth. There are other people just like me that have a lot of problems. Graduating from this program opened doors. I got my GED, and I'm going to see what my purpose is. So people can feel the sense of accomplishment as well and be able to move forward with their lives. A lot of people they face several different challenges, and it's difficult to decide to engage in programs, principally if you are involved with criminal justice systems or with DCF. And I think that Imani allows people to engage without this sort of control, and if the program doesn't work for the person, they're going to be punished from these systems. Also, another quote I like to read for you: spirituality spiritually is a motivation. Sometimes it is the only thing that you have. Help me validate my feelings because I have so many thoughts and I believe that it is important. My power comes from my thoughts, my values too. So again, engaging with people and through focus groups, community conversations, we are able also to capture how Imani is changing people's lives.
Thank you, Dr. Costa. And I wanted to point out that this data is based on, what was the N?
We collected data from almost 1,000 participants altogether.
Thank you. And that's really significant. I will say that there aren't many programs in our state of Connecticut, let alone in the nation, that have seen over 1,000 people walk through our doors. at that high of a number, particularly Black and Brown individuals. So some lessons learned. The importance of a church liaison. You see how powerful Reverend Robin is, and just having those connections and collaborating and doing things right up from the front in terms of participatory, the participatory process. The importance of culturally specific advertising, ongoing training and supports for our facilitators, developing the capacity of the churches to enhance or develop recovery ministries over time. There really is a need to develop more collaborative relationships and partnerships with MAT and other addiction initiatives. However, more needs to be done there. And there needs to be more effective ways to study harm reduction and choice. Choice was a huge element of what participants described in terms of why Imani worked for them, having that sense of autonomy and that sense of choice. And then in discussions with our colleagues here, and many of our folks over time have also talked about the importance of family and developing support for family. So here's the good news. So Dr. Jordan and I just found out we do not even have a notice of award yet, but here's a snap of, so we've been awarded a U01 as of 9/23, hot off the press. So we're really excited to be able to study Imani Breakthrough as a RCT. And here is what we are proposing to do. So this is our conceptual model. So the moderators, social determinants of health, and the treatment condition preference. These are the key components that we just talked about, faith-based, the 8 dimensions of wellness, the 7 domains of citizenship, which are acted out via those 5 R's, the education and training and MAT and harm reduction, choice, autonomy, and then the classes. And these are target mechanisms. So what's really interesting about the way we are now proposing to do this as a RCT is at week 4, individuals will have choice in RCT enrollment, and then if they indicate they want to do so, they will then be assigned Imani telemedicine or Imani MAT referral. And the telemedicine portion of this is the addition, which is that we're going to have docs be able to be on site through telemedicine approach under the supervision and guidance of Dr. Jordan, who will initiate SUD treatment and MAT for those who are wishing to do so. And again, MAT is very expanded, including just even offering people help with trying to, if that's sleep meds, if that's, smoking cessation, whatever that is for that individual. But the hope is trying to figure out a way to engage more people in the resources that they need related to medication for addiction treatment. So we're very excited about this opportunity to study out further over the next 5 years, and we certainly will be in touch with you all about those findings as we engage in that this new process. So thank you for your time, and we're now just going to open it up to questions, suggestions, hear your ideas, and all of that.
Great. Thank you so much, Dr. Bellamy and the entire Imani team here presenting today. It was really a really interesting presentation. I just wanted to open up the floor to questions if anyone has any. I have a couple myself that I was hoping that that you could answer. The first is I'm curious about your success rates for intervention. First of all, how do you define a successful intervention? And then if you have any data on how this compares to other programs targeted at Black and Latino or Latinx, and also versus other faith-based in general. So that's one question. And then related to the faith-based also is, although you said in the beginning of the presentation or rather, although you said during the presentation that people do not have to be congregants to participate, I'm wondering, given the fact that faith is such an important part, as you pointed out in the beginning of the presentation, in Black communities, are there disparities between those people who were belonging to those congregations and those who were not in their in your success rates or in your successful intervention?
I was going to say, I can just say that you, Grant, and share with you. I'll just say one thing, because there are two questions here, and maybe Mark can talk about some of that too. I will say that the advantage of what we just experienced with the Imani program and doing this through the state of Connecticut was that we were able to really have a program just happen, in its natural form, and then collect data and see how it works. And now we get to study it as an RCT. So we'll now be able to, have a whole battery of, instruments that we'll be able to get a better sense of, are there differences between those who are parts of congregation versus those who aren't, so we'll be able to study that a little bit more intentionally moving forward.
Can I also say something also around just the faith-based part of it and them being members and not members? I think it's just as many. Some of them are not members, as I mentioned. Some of them will never, be members of the church. But also, even myself, I have been in the clinical field for over 34 years, and also have directed inpatient and outpatient program for those that are using substances. And one of the greatest things about the Imani Project is that, and one of the things that I always struggle with, and I think that other programs struggle with, is that a lot of programs are more so modeled around, first of all, a kind of male model in many ways. And so we have both male and females that are really a part of the Imani Project. The other thing is that it's not always culturally sensitive also. And also one of the biggest things is more about controlling them in that environment versus teaching them really how to live in their community in recovery around things that are familiar, that don't change when they go back to their community. So I think that one of the things to me that has been the greatest asset of the Imani Breakthrough Project, that not only they're receiving those services in their community, they're seeking how to live in their community based on, their mental wellness as well as their, substance use, and being able to maintain it, and also are linked to people that are in the community, not just during the group, because many of the participants that are in the Imani Project, they don't just come to the group and never come back to the church. They are at the church for 24 hours, if they can, 24 hours a day, but also because they see the church as a place that they can come, always in touch with the facilitators of the actual groups and the intervention. And so I know we're in the process of studying it, but I'm going to be excited because from what I can see, the numbers that have gone through this program and have actually completed the program outweigh a lot of numbers that I have seen in my 34 years.
Thank you.
Just very briefly, I see some challenges in comparison because of uniqueness of this program. A general comparison that is very we feel very good about is retention. We have better retention or people completing the program when compared to other programs. So I think that's amazing. It's a 22-week program, and the number of people who complete the program are generally higher when compared to other groups for people with addiction. And I think we're addressing a population that traditionally doesn't seek treatment, so we're not addressing, and I think that this is very powerful as well. The other aspect, which is we haven't discussed much, but it's sort of people addicted to multiple substances which come to the program. We know that, and we're seeing this in the trends of the opioid crisis and the overdose crisis, is that there is an opioid component, but there's also multiple substances as a factor in overdoses. So I think the program gives the opportunity for people, and the majority of participants from our data, they use multiple substances. It's not only opioids, but it's opioids, alcohol, cocaine, and other substances. So I think this is also very interesting for this program.
Thank you so much. I really appreciate your response, and I'm excited also to see the next phase of what you're able to collect. We have a couple of questions here from Representative Liana Kassar from the Rhode Island State House. She says, "Thank you for the presentation. Can you explain the way in which this is expected to be implemented here in Rhode Island?" And then the second question is, how long has this program been in place? And I guess the third is, what is the experience of the longer tenured churches? So the first question is about the implementation in Rhode Island.
So first of all, I will say that the Imani program has been in place. I think we're going into our 5th cohort with the Imani project, so about 4 to 5 years. I will also say that we're excited that we're going to be doing this work with Rhode Island, and Linda Mahoney at the state is the person that you probably really should connect to. But I will say that we've been involved in having participatory conversations with the churches, and we're going to be available to provide training and share our resources and share ways in which we've collected data so that we can help do some analysis once the data is collected. I think that what we're working on is trying to modify this so that it meets the needs of the folks in Rhode Island, and that's really central to the work that we do. So I will definitely be in touch as we're rolling it out, but I know that we're still in the process of working those things out.
And I think the other one was the tenure of the churches being involved.
His experience of the longer tenured churches was the question.
The experience of the longer tenure churches in terms of, I just want to make sure I understand the question.
That's the question. What is the experience of the longer tenured churches? I don't know if Representative Kassar is here, if you want to further.
I'll unmute her so that she can ask her question. Liana, you should be good to ask.
All right, great. Thank you so much. And thank you everyone for the information. It's a really, I look forward to learning more about the program, and the community has so much need. And so my curiosity is, so you've got the 12-week program and then the following 10 weeks. I'm just curious about sort of how has the ongoing sort of engagement of the churches? Is it something that sort of get all of those folks who started at the beginning? Is it still ongoing, and what does it look like now, 4, 5, 2, 3 years after doing that initial cohort? Like, are you repeating cohorts, or is it sort of taking that cohort and helping them move on?
Sure. So the churches that have been involved with the project, we first started out with the 4 African-American churches. And so that's when we started the project, when we first kicked off the project. And then a couple of years later, we added the 4 Latinx churches. So we have a total of 8 churches that are involved. And so the churches that are actually involved on with the African-American churches, they are still very much a part of the project. There's only one church, and that was on the Latinx side, that we actually ended up changing that church, but we have another church that's actually in place. As I mentioned before, many churches are really wanting to be involved. with the project. And so those, the churches that are involved have continued to be, really very committed and excited about it. And also, receptive. And people are actually, even before the cohort ends or right after it ends, are ready to start the next cohort. And most of those churches that are involved have been churches that are established, as I said, in the community and have been in the community for many years. One of the oldest churches that has even been in the New Haven community has been in existence for 197 years.
Great, thank you. I think Dr. Rich, Joe, do you have a question?
Boy, this is really very exciting and touches on so many important things that that we've been missing, not only with the opioid crisis, but this whole, I'm thinking we should teach this to all the children, all this citizenship and all the various numbers of things you have there. My question, I'm not sure I completely understand the intervention and how it works, but one thing that a lot of us have been frustrated on is in the 12-step approach to addiction, which is heavily faith-based. There's a lot of resistance to the medications, which it doesn't. There's this sort of notion from AA that you really have to bottom out, and you have to reach bottom, and then you have to kind of give yourself up to a higher power and build yourself back up, and that using medications is somehow cheating, or you're not really in recovery if you're on methadone, if you're on buprenorphine, and that really has held back a lot of people, and that bottoming out with Alcoholics Anonymous may mean that you're homeless and you're struggling in the gutter, but bottoming out with opioid use disorder is you're dead. So that really doesn't work for me for opioid use disorder. So I'm you mentioned the connection between AA and the churches, which is obviously wonderful. And AA is, I'm a big fan and supporter of 12-step programs, but except for that one issue about that you don't need, that you're not, in many meetings, you're not allowed to even mention that you're on these medications. And so, the problem is somebody comes in, oh, now I've got this disease and what should I do about it? Oh, go to some meetings. So they go to a meeting. Half the people in the meeting that are in recovery from opioid use disorder are on methadone and buprenorphine, but nobody talks about it because it's discouraged. So my question is really, how do you deal with that, and how, the training for the people involved is wonderful, but to me, sort of a critical component is the training for the religious leaders who are involved in the program. And so maybe you could address that concern about the negative attitudes towards medications and the training for it.
Thank you. So the first thing, appreciate your question. When I mentioned that we're involved with ANA, AA and NA, that's just one option of what's available to people in terms of community supports. What's very different about this project compared to many of 12-step programs or other programs is that you can come in using, right? So this is a harm reduction. So harm reduction means it's okay that you use whatever drugs, whether those are prescribed or not, right? So, and we're here to help you decrease that use over time. And so that's really key to our philosophy around Imani. The other thing is that we really introduce people to medication for addiction treatment. So really moving away from that other stigmatizing language that we've used in terms of how we refer to MAT, but really looking at medication across the board. Like I said, it could be medication for sleeping. It could be medication to help people stop smoking. And over time, we're hoping that as people get a better understanding that, medication can work, can be effective. It may not be what all want to use, but it is available as a resource for those that need it. So we really try to focus on that. And that's really key to our trainings. And as Pastor Robin was saying, that it's really important that the pastors also attend the training and the liaison work that she does with the pastors presents to them an understanding about harm reduction and about taking this on as part of their church ministry.
Also, just jumping in, an important aspect of the program is that in between meetings, facilitators will meet individually for those who want, for a one-on-one coaching session where they're going to work on their individual goals. And it might be from finding housing to addressing debt issues, or to also connect to services. So there is sort of this option of an individual individualizing the program as well. It's not like everybody needs to follow the same model, the same steps. You know, you have the opportunity to individualize your experience, and it's very powerful in this sense.
Yeah.
Was
If I could add something also, I just wanted to also say that, you know, as Dr. Bellamy mentioned, that very much a part of the conversations that I have with the pastors, the meeting, as well as the educational component of this, is to really educate them on the various, you know, models of treatment. And also we talk about medically assisted treatment, because they want to know too, they want to make sure, you know, also that they have, you know, also a clear understanding so that they can also support it. And what I mentioned also, and is that AA met in the basement of the actual churches. That's how they got started. Not necessarily having that an affiliation in terms of how they operate, but really that's where they began to meet. But, you know, again, it's really just really understanding that we are in the business of healing. And so a part of that is that we also meet people where they are, and we work with them from there. And that's why, again, as we talked about earlier, that's why it's important that pastors are involved with it, that they do have an understanding, and that they're educated on these things so that they can also support them as well and support the program.
So is that education of the pastors part of the Imani Project, and how's that operationalized?
Yes, so the educational part of it is part of the program in which we actually meet with, as I mentioned, with pastors, as well as, you know, in their churches. We've had various educational component. The educational component is that we teach, you know, we talk about addiction, we talk about harm reduction, we look at mental health, we look at ways in which they can actually sustain the project by looking at, and many churches also, as I mentioned, go beyond that, but looking at the fact that they have social workers, they have clinical psychologists, they have doctors, they have lawyers that are in the churches, and really doing some asset mapping to see how they can actually sustain the project even beyond, you know, where it is right now. So yes, and so that's a big part of it, and teaching them about the different, you know, medications and stuff like that. So yes, they do. And we talk about that. Some of them may call or ask about that. And so we, you know, could also, even after that, but we do have an educational component of the project for that purpose.
And are the pastors running the program? Are they working with the facilitators, or they're just there and the facilitators are running the program?
Well, what they do is that they continue to support them. They're very active and, you know, talking to their facilitators and meeting with their facilitators. But both Graziela and also Mark are the ones in which the facilitators, you know, touch bases on, you know, the regular, you know, basis as well. But the pastors are still very much a part of it and very much supportive of the project.
We have pastors that are facilitators with us. We have churches that after Imani started, they organize a call champions, and they offer these Sunday breakfasts and invite the community and talking about not only about the program, but about health and opioids and the crisis, and educate the community. What I think it's important to say that Imani opened a lot of possibilities for all the members and the leaders, faith leaders at this church, to start to talk about opioids, just to find a way to normalize this conversation and have the community get together and work with them. And that's why we keep on going in educating and talking and provide support, and the church is very engaged into the program.
Mhm. And I was going to also say that, you know, as a pastor, I'm also very much attuned with and also involved with, you know, the opioid epidemic crisis. And so in many of even our ministerial alliance meetings that are located in our local areas, as I mentioned before, many people come and we go to seminars and we go to workshops and all of that. So we are always, even ourselves, being educated around, you know, some of the things that challenge, you know, our people in our community. As we said, that the church, you know, the world is our parish. And so we can't really, you know, minister to people if we don't know what's going on with people and understanding that. So we're very much involved in that, even in our own, you know, ministerial alliances, but especially with the Imani Breakthrough Project, with those pastors, we make sure that they can actually teach that if they need to.
Thank you.
Okay, thank you so much. We're over time. That's all we have for questions. I'm certain that the Imani team would be happy to answer your questions offline if there are further questions. I want to thank everybody for coming today to a really interesting and informative lecture by the Imani Breakthrough Project team, and on behalf of COBRE on opioids and overdose, Rhode Island Hospital. Thank you all for coming, and we'll see you next time. Thanks.